Hi, I'm Dr. Annette Hulse. I want to talk with you a little bit now about the evidence behind the cranial concept. I have a few objectives in this lecture. One of them is to introduce the phenomena of osteopathy in the cranial field as elucidated by William Garner Sutherland almost 100 years ago. I want to demonstrate why that paradigm is the best thing that we have existing in medicine today. And I want to more generally advance a more robust use of the concept of evidence-based medicine. Now, I like to say I am from Missouri. You can tell I'm from Missouri because I say it correctly. But more importantly, Missouri is the show me state. I don't believe anything just because somebody tells me. You have to show me. I always want to know why and how. In fact, my first day of medical school, we were going around introducing ourselves, and I told my fellow classmates that I went to medical school to satisfy my inner 3-year-old. I always want to know why. Why? A couple things to know about me is I was originally trained as an engineer, specifically a civil engineer, structural and environmental engineering. And I say this because I'm going to refer back to that a couple of times later in this talk. So before I went to medical school in my 40s, I worked in management consulting, and my specialty was decision making under uncertainty. Companies came to my firm to help them make decisions where there was a lot of money at stake. But often there's things that are inherently uncertain. You can't know them. One of those are things about the future. For practical purposes right now, some of them are things about the human body. So I'm going to refer back to these things throughout my talk, and I want you to know that's where I'm coming from. So let's start by talking a little bit about evidence-based medicine. This term often gets dumbed down. To be evidence-based medicine is just about evidence. And then it gets dumbed down further to evidence is just about randomized control trials. But that's really a very overly simplified version of what evidence-based medicine should be and was meant to be. Now, this is the definition from the seminal paper by David Sackett in 1996. That evidence-based medicine is a combination of all of the relevant scientific evidence, the clinical judgment of the physician, particularly on how that evidence applies to the patient that you're treating, and the patient's values and preferences. So let's go back to that concept of all of the relevant scientific evidence. What is evidence? Well, it's everything we know about anatomy, about physiology, about pathophysiology and dysfunction, about the etiology of disease and dysfunction, risk factors, and then also the efficacy of an intervention or treatment. And really, randomized controlled trials only address that last one. So when we look at evidence-based medicine, we really want to understand the whole context of what's going on. It's all the information that informs the process of both diagnosis and treatment. In addition to the lecture objectives I laid out earlier, I really want to help you get to this concept of asking why, being very discerning about how you evaluate information and bring it into the larger context of everything else you know. So let's start with, what is osteopathy in the cranial field? Well, in the schools today, it's also known as osteopathic cranial manipulative medicine. Those of us in practice don't actually identify with this name because in truth, it's not just in the cranium. It goes through the entire body. You could say it's the extension of osteopathic principles to all aspects of the body, including the head. But most importantly, and this is really what osteopathy in the cranial field is, it's osteopathic treatment using the primary respiratory mechanism. Which begs the question, what's the primary respiratory mechanism? The primary respiratory mechanism is the inherent, subtle, rhythmic motion that underpins all body functions. We call it the primary respiratory mechanism because it's primary, it's fundamental to life. Respiration, because at the most basically level, is cellular respiration. It's a common term for those who have studied biology, the movement of nutrients into the cell and waste products out. And it's a mechanism because it's a system of dynamic, interacting biologic processes. So the primary respiratory mechanism exists through the entire body. It is most obviously expressed and the easiest to feel in the cranium and the central nervous system. And this is one of the reasons I think where this idea of it's cranial comes from. But the important thing to know is it's not just in the head, it's everywhere. It's not a separate part of osteopathy, it's just osteopathy. And in fact, although this is something that osteopaths have known for decades, we now actually have clear definition that the fluctuation of the cerebrospinal fluid does in fact go through the entire body. This is a paper from last year showing the CSF flow extending all the way down the peripheral nerve shoots to the very end, unifying that central and peripheral nervous system. And in many of the press releases about this paper, I saw they used actually the picture of the peripheral and central nervous system dissection that was done by osteopathic medical students in the 1920s and is on display at the Museum of Osteopathic Medicine in Kirksville. So talk about Dr. Sutherland's phenomena. Let's go through them. What are they? So I'm going to talk about 4 phenomena in the head. He actually originally articulated the articular mobility of the cranial bones and added in the mobility of the sacrum between the ilia. For the purposes of this talk, I'm just going to be focusing on the cranium. So I'm not going to talk about the sacrum, but that's the other part of this phenomenon. So you'll often hear, particularly MDs and dentists, will say, well, the skull is one bone, it is fused. I know that's not true. And I know that that's not true because I can do this. This is what's called a Bouchain skull. I was teaching a few years ago, and there was a dentist in the course. I was talking to him at the airport after the course was done, and he was commenting. He said, "This is mind-blowing. I wish I could convince my colleagues that the skull is actually in parts. It's not fused." And I said to him, "Haven't they ever seen a Bouchain skull?" Which is what this projection is called. And his eyes got big. And he went, "Oh, right. They're taught in dental school. MDs are taught in medical school that the skull is fused, but at the same time, they learn the individual bones. They see pictures of them, they see them in projections like this. And so they've studied the disarticulated bones in front of their eyes in one context, but then in another context, they were told they were fused and they didn't put those two things together and notice the dissonance between what their eyes told them versus what somebody said to them. Now, let me contrast this to the sacrum. This is a sacrum and it is truly fused. You cannot disarticulate it. You cannot take the pieces apart and put them back together. The only way to unfuse this bone is to break it. And I know, in fact, the pieces of the cranium do fit together very tightly. It's like a very complicated 3-dimensional jigsaw puzzle. And just like this jigsaw puzzle, of which this is a simpler picture, there are some ways of motion, some directions of motion that are allowed and others that are not, based on the geometry of the way the pieces fit together. So when we're born, there are no sutures. We all know about the fontanelles in an infant. It looks like this. The sutures will develop over time. Oh, how do they develop? Why do they develop? How and why being the corollaries to each other. They develop around the motion that already exists so that that motion can continue to happen. So how and why do we go from these wide open smooth sutures in an infant to an adult skull where the sutures are so complex? Let's look at this one, the coronal and the sagittal sutures. As I told you, I originally studied as an engineer. I learned about this in design classes. We use them all the time. They're expansion joints. And in fact, if the skull can't get enough motion, if the skull can't expand enough in this area where the coronal and the sagittal sutures are, it will create a workaround. These are called Wormian bones. Now, I don't know what this person was like when they were alive. I only see the outcome, what their skull looks like after they're gone. So did they have a compression across these sutures? Maybe they had a level of cranial synostosis. But in any case, that central nervous system needed more room to move than was allowed in the way that we typically see it. So it created new areas around which it could move. So the sutures developed from these simple edges, very straight and flat in growing infants, to these complex interconnections in grown adults, ossifying in the areas that don't move and allowing the motion in areas that do move. So we can actually tell how the bones move based on how they've ossified. And I want to point out these very complex, complicated interconnections in grown adults are actually the same from person to person to person. So we can figure out how these bones move based on how they form, ossify, and form. We already saw an expansion joint. Here's another example. This is a different kind of suture. It behaves differently. It acts differently. It's called the SS pivot or the spheno-squamous pivot. It's where the sphenoid and the squamous portion of the temporal bone articulate. So at this location, we have what's called a bevel change. The bones overlap each other. On one side of the bevel, the temporal is on top and the sphenoid is underneath, slides this way. On the other side of the pivot, that bevel changes, and the sphenoid is on top and the temporal is on the bottom. So we can see that here. The arrow points to the place of the pivot, the bevel change. Above that, the sphenoid is on the outside and the temporal bone is on the inside. And below that, the temporal bone is on the outside. And you can see that here because looking from the outside, above the pivot, we see that bevel of the temporal bone where it slides under the sphenoid. So now I want everybody to do this. Take your hands and I want you to interlock them like this. It's easy, right? Now, try to rotate. You can rotate this way, no problem. But what about the other direction? You can't. You can't force them together more. So you've created a place where literally can rotate one direction, but out not the other. And at the point where those fingers are overlapping, there's no motion at all. And conveniently, at that point where there's no motion at all, at the SS pivot, is where the anterior branch of the middle meningeal artery crosses that suture. So it's protected because there's no motion allowed there. So we have these sutures that start with very flat, smooth articulations between the bones. But as the human being grows, they get more complicated. They become three-dimensional. They differ in different parts of the skull. And they're reproducible from person to person to person to person. And so this concept of we should ask why. This doesn't happen by accident. It happens for a reason. And if we make this observation of a phenomenon, we should be able to answer that question, how and why did it happen? Or at least have a reasonable hypothesis. There actually has been a little bit of research specifically on how these bones move. In the 70s, there was research both in the US space program and the Russian space program, looking at how those cranial dimensions change over time. And what this research showed was that the cranial dimensions in the AP diameter, AP, and side to side would change a third to a half of a millimeter. And that those changes would fluctuate at 6 to 14 cycles per minute. And there's a summary of that research on the Cranial Academy website with the URL here. More recently was a paper a few years ago in the Journal of Bodywork and Movement Therapies where they looked and directly measured the rhythmic motions of the human head. It's the only study I'm going to show you that was looking for evidence of the cranial mechanism. Everything else I'm going to show you in this talk was done for other reasons, and yet will still support the science of osteopathy. In this case, what they found was now we're measuring the outside of the head, the motions of the cranium itself. And there were multiple frequencies going into this, but what they resolved into was what they called the third rhythm. So the thing that was neither vascular nor thoracic respiration. So they called it the third rhythm. It has this periodicity of approximately 12 seconds that you can see here in this graph. So before I go on to the next phenomenon, I want to take a little bit of a detour and review the blood-brain barrier. It's a term that gets used a lot. Lots of people go crossing the blood-brain barrier, but a lot of people, and particularly doctors, don't really know how it works. And so that's what I want to talk about now. So let's look at the brain. It really is not a very vascularized organ. Compare this, for example, to the liver or the kidney. And yet it consumes somewhere between 10 and 25% of the body's glucose and oxygen. Well, how does that happen? What we colloquially call the blood-brain barrier is actually made up of two different components that an anatomist would differentiate between. The barrier directly between the blood vessel and the brain, and then the interface between blood vessels and the CSF. So that's the indirect blood to CSF to brain parenchyma. So the first of these is that barrier around the blood vessels themselves. It's a tight barrier. There are three different layers or kinds of cells between that blood vessel, isolating it from the rest of the central nervous system. There's an endothelial cell around the artery itself, and then pericytes, and then astrocytes. So if you look at this, you have to imagine that that is not an easy thing to get across. Some things will, but not a lot. It really requires active transport. In contrast, the second part is the blood to the CSF to the brain. This is primarily done through the choroid plexus. Choroid plexus is this highly vascularized structure in the brain with a very dense network of fenestrated capillary loops that help in the synthesis, secretion, and circulation of CSF, cerebrospinal fluid. It's a very unique structure, and it's a key source of nutrients to the brain parenchyma. In addition to the fact that it's also the sink for central nervous system metabolic waste. So it's both nutrients and waste that get filtered through the CSF. In fact, the functions of the choroid plexus are often described as being analogous to those of the liver and the kidney. Beyond forming this barrier, the choroid plexus is a mediator of leukocyte trafficking, inflammation, circadian rhythm, and more generally, the gut-brain axis. So what's in cerebrospinal fluid? Well, a whole bunch of things. Ions, vitamins, glucose, peptides and proteins, growth factors. When I was in medical school, I was taught that the purpose of cerebrospinal fluid was just as fluid, as water to provide buoyancy to hold the weight of the cortex, the cerebral cortex, up off the brainstem. And then later in infectious diseases, I was taught that one of the ways we differentiate between bacterial meningitis and viral meningitis is that the glucose levels in the CSF is low in bacterial meningitis, but normal in viral meningitis. And even then, I thought, why is there glucose in the CSF if its only role is to create buoyancy? And in fact, that's because that wasn't its only role. It has a much more important role. So let's look at this one, glucose. I said earlier that the brain consumes between 10 and 25% of the body's oxygen, but also glucose for energy. So the cerebrospinal fluid contains a lot of glucose. This is how that basic function of energy gets to the brain parenchyma. There's a couple differences between glucose and oxygen. One is, as we remember from studying our hemoglobin dissociation curves, oxygen doesn't dissolve very well in fluids. So CSF is not an efficient way to deliver oxygen to brain cells. It needs to go attach the hemoglobin through the vasculature. The other difference is glucose is a very big molecule compared to oxygen. And so remember that first part of that blood-brain barrier with all of those cells requiring active transport to move things across. It would be hard for the blood vessels to supply all the glucose and get it through that tight barrier. Oxygen, on the other hand, is a very small molecule and it diffuses across. So the oxygen is delivered by the blood vessels because where it can be carried by hemoglobin, and the glucose is delivered by the CSF where it can be efficiently transported. So now let's go back to Sutherland's second phenomenon, the inherent motility of the central nervous system. So we have evidence of this all the way back, at least as early as 1987, where there were observations of pulsatile brain motion. The authors described what they believed to be the first observations and measurements of motion in the human brain, occurring extensively in the internal regions, specifically the diencephalon and the brainstem. So let's look at some videos that have actually been done on the motion of the brain. This study shows us motions in the brain tissue based on amplified MRI. Now, I want to talk about a little bit of imaging for a moment. The body is very complex. We can't take a camera and go inside and see everything. So we do imaging, but different imaging shows us different things. X-rays show us a different picture than a CT, which shows us a different picture than an MRI. And even with an MRI, we get different representations if it's T1 weighted versus T2 weighted versus PD weighted. And it's manipulated to enhance certain parts of the signal that it picks up. I think of this as a little bit like Where's Waldo? So you're going to find different things depending on which parts of the signal you enhance. That's true in this paper too. They found brain motion along multiple different frequencies, somewhat similar to the paper we saw in cranial motion, and then amplified those signals at each of the different frequency levels so that you could see the contributions from each one. The highest amplification they found in the band that goes along with the frequency of the heartbeat. That's to be expected. And this is what that looks like. So now let's look at all of the different frequencies they analyzed in one single picture. We can now measure motion in the brain along multiple different frequencies. So we've seen evidence of that direct motility of the central nervous system. Another way that the central nervous system moves or moves fluid are these microscopic cilia in the ventricles that organize and move the fluid around. We also have a video of that. You see here how those microscopic cilia regulate the flow of CSF fluid through the ventricles. And then the third piece of evidence we have for motion or motility in the central nervous system is actually the expansion and contraction of the brain. This paper actually looked at the converse of that, which is the expansion and contraction of the extracellular space around the brain. That expansion and contraction affected the CSF paravascular flow into the parenchyma, what was called the glymphatics. This was the paper that identified the glymphatics. And what they found, one of the things they found was natural sleep and anesthesia both were associated with a 60% increase in the interstitial space in the parenchyma of the brain. So, of all these pieces, we have motile cilia that we can see moving fluid. We can measure parenchymal motion with cardiac, respiratory, and several other cycles. And we see the actual expansion and contraction of the CNS cells at a minimum during sleep. So that brings us to the third of Sutherland's phenomena, the fluctuation of the cerebrospinal fluid. So now we're getting to something even more complex. These are what are called the Navier-Stokes equations. It's how we mathematically would describe the motion of fluid. They're actually not solvable. And harking back to my engineering days, I spent way too many hours trying to solve approximations to these equations in fluid dynamics. When we can't measure something completely in its complexity, we break it down into pieces, just like we did in as imaging studies, where we looked at an MRI and weighted it differently to see different components. We can do the same thing with the motions of the CSF. Now, when I was in medical school, I was taught the CSF had a very simple circulation. It was synthesized and ejected out of the choroid plexus. It circulated around and then was reabsorbed back through the arachnoid villi. It's not that simple. In fact, it was never that simple. And yeah, we had that paper all the way back in 1987 that showed not just the pulsatile brain motion, but also simultaneous reversal of CSF flow direction in the basal cisterns through the fourth ventricle. So when this was included in Guyton Hall in 2006, it was already 20 years out of date, but it was still what we were being taught. So when we do these components, the components will end up going together in ways that you may not expect. And I want to give you an example of that, which is a car piston. In a 4-cycle engine, the pistons go up and down, but those are translated into rotations of the wheels that are attached to them. And so even though you have this up-down motion, inside the car, what you observe from the outside is that it's rolling down the highway. And so when we look at these components of CSF, we have to be careful not to say, this is the answer, it does X, only that it is a component of it. So there's lots of literature on the fluctuation of the CSF, a lot. if you look broadly across that literature, you will find people who have identified contributions of the CSF fluctuation from cardiac impulse. Like the motility of the brain, there's contributions to the fluctuation of the CSF from the cardiac impulse. There's contributions from the pressure changes that come with thoracic respiration or secondary respiration. There are contributions from posture. There are contributions from stages of sleep, like we saw in the glymphatic paper. And then there's contributions from venous return, which I find kind of interesting, separate from the cardiac impulse. And that was this one, which showed CSF dynamics and cerebral venous blood flow were closely communicating and also had a relationship to respiration. And I'm going to come back to this when we talk about the dura. And that's an important piece to keep in mind when you're reading these papers, because sometimes the papers will leap to the conclusion CSF is driven by cardiac impulse or thoracic respiration. And it's true that it's a component, but it doesn't mean that it's the entire story. So I said earlier that that first paper on the motion of the cranial bones was the only one where that was in any way related to osteopathy. Most of this research is being driven by the multi-billion-dollar drug market that could come about from a pharmaceutical treatment for Alzheimer's. Simple answer drugs didn't work. So now science is going back to really try to understand much better how the brain, the central nervous system, and the cerebrospinal fluid really work. And that's what's producing all this research. So this is a paper that came out a couple of years ago that shows that the subarachnoid space actually is divided by this fine mesothelium. It's a couple of cells thick that divides that fluid, that CSF, into clean and dirty compartments, and further demonstrates the sophisticated role of the CSF in both transporting nutrients, but also transporting and removing waste. So we talked about the cilia in the motility of the brain. This paper looks at the role of the cilia in actually moving the fluid around and how they found in their look 3 different components influencing the flow of the CSF. 1, those motile cilia. 2, the cardiac impulse. And 3, actually motions of the body, body movements and posture. So again, as I said, we interpret these, we take the body of them to say we've demonstrated contributions from all these very many things. And the reality is some combination of them all put together, which, like in the Navier-Stokes equations, we can't completely solve. And that's okay. And now I'm going to hark back to my previous life of making decisions under uncertainty. We're used to this. I know the answer or I don't know the answer. But sometimes the answer is unknowable. And just giving up and saying, I don't know, is not an option. So we get as close as we can. We stay there, living with the uncertainty and let the science evolve, but go ahead and use what we know, even if it's incomplete. So the last paper I want to talk about is this one looking at the fluctuation of the CSF. This paper found fluctuation of CSF during slow wave sleep. And specifically, they found it with a cycle, about a 20-second cycle. And in this 20 seconds, the direction of that flow was biphasic, meaning it changed the direction in the fourth ventricle in the middle of the cycle and then back. And in a press release from one of the researchers, he said, the movement seems almost tidal. They saw exactly what Dr. Sutherland had felt and also described as the tide. Now, they only found it during slow wave sleep. That's okay. Remember, we have uncertainty, and we can only find things we only find things when we're looking for them. But second, it's this where's Waldo again. And if you're looking for the girl in the yellow bikini, you might not notice the man in the large hat with the dog. It doesn't mean he's not there. What they found, this is not what they were looking for, but it was the biggest thing in the picture during slow wave sleep. So they identified the tide even when they weren't looking for it. And this is the video from that study. Now you'll notice that blue light that shows up in the fourth ventricle. That's that change in direction, that biphasic response. You'll also notice that this is not a 20-second cycle. My assumption is that they have sped it up for purposes of this video. I don't know that, but the paper very clearly said 20-second cycles, and this is the video that they released to go along with it. And they concluded that the results showed that the sleeping brain exhibits waves of CSF fluctuation on a macroscopic scale, which, as we've seen in many of these other studies. And that those CSF dynamics are interlinked not just with hemodynamic rhythms, which a lot of these other papers have shown, but also with neurodynamic, that motility of the central nervous system. And then the last of Sutherland's phenomena of osteopathy in the cranial field is the mobility of the dural membranes. So the dural membranes, which we also sometimes call them meninges, are these three protective layers of tissue that surround and support the brain and the spinal cord. They provide a framework for the central nervous system. They help maintain its structural integrity. They separate it from the rest of the body. The dura mater, the outermost, thickest, and toughest layer, is dense connective tissue. It lines the inner surface of the skull and actually comes around to form the tent and the falx. Then the next layer is the arachnoid mater, which is this thin spider-like membrane. It lies between the dura mater and the pia mater. Pia mater is directly on the surface of the brain and the spinal cord. And it forms a space, a subarachnoid space, which is filled with CSF. And as we already saw, that subarachnoid space can get divided into dirty versus clean CSF. The dural membranes are really a protective barrier. They shield the brain, they support it, they give it structural support, they maintain the fluctuation of the CSF, and they form the dural sinuses. You may not have ever thought about it, but there aren't really veins in the brain. The blood that comes in via the arteries collects in the venous dural sinuses, which are the spaces between the two layers of dura. In the falx and the sagittal sinus, vertically, we have two layers of dura, one from the right and one from the left, and they form a space. This is the sagittal sinus. This is where venous blood accumulates and comes back down into the confluence of sinuses and the transverse sinuses. So the tent also has two layers that are running horizontally. Between those two layers at the outside where it attaches to the skull, there's a space, and that's the transverse sinuses. All of the blood drainage out of the brain comes through these dural sinuses, these spaces between two layers of dura, until it gets to the jugular foramen, and then it becomes the jugular vein draining out of the head. Now, we talked about the mobility of the dural membranes. Well, I know that they move because I've seen it do this. In an epidural hematoma, you can move the dural membrane. But more importantly is to think about, how does that venous blood in the dural sinuses get returned back to the heart? Is it gravity? Well, the things at the very front by the falx, are actually below what's here at bregma in the sagittal sinus. How are they draining this way? What about when you're asleep? Well, what if you're in Trendelenburg position? Is it gravity? Is it fluid pressure? Well, to some extent, the presence of the CSF will create a fluid pressure on those dural membranes. But more importantly is actually the motion of the dural membranes, right? The membranes move and pump that blood out, and they move both because of the motions of the bones that we started, and that as the parietals move like this, the dural membranes will go with it to create a pumping motion. Same thing with the transverse sinuses, but also from the fluctuation of the CSF. As the CSF goes in waves, because those dural membranes are flexible, they will also get wave activity on them, and we get this venous return. So we've gone through the phenomena that Dr. Sutherland described for osteopathy in the cranial field, the articular mobility of the cranial bones, and we saw why that must happen. The inherent motility of the nervous system, we saw direct evidence of it, and again, why it must occur. We saw the fluctuation of cerebrospinal fluid, again, direct evidence, and also the indirect evidence of how it's necessary to transmit nutrients to the brain. And then the mobility of the dural membranes. And then let's talk about the evidence that it must happen. If the nutrients are in the CSF and it's coming from the choroid plexus, then one option for the distribution of that nutrients would be passive diffusion. If that were the case, though, what we would expect is that we would have the most brain activity closest to the choroid plexus, where all the nutrients are, and the least brain activity furthest away from the choroid plexus and its nutrient source. Instead, that's not what happens. When we look at something like functional MRI is actually measuring metabolic activity, the metabolism of glucose in the brain, and we use it to figure out what is being processed where. And you will notice in these pictures of a functional MRI, the high glucose activity areas are not the ones closest to the choroid plexus. In fact, in these pictures, they're quite far away. So the CSF has to fluctuate in order to carry those nutrients away. And now we get back to the motility of the central nervous system, which is what's making that fluctuation happen. And this would be why. It's how it distributes nutrients to the whole central nervous system. So as I said earlier, I'm from Missouri. I don't believe anything just because somebody tells it to me. The teachings of Dr. Sutherland, however, fit everything that I know, everything I can see and feel and perceive, and all of the new science coming out too. I read so many papers in this realm that have comments like, this upends 100 years of dogma, or no one knew this until now. Well, actually, the osteopaths did know. Dr. Sutherland figured it out almost 100 years ago and elucidated many of these things that the research coming out today still is consistent with. Nonetheless, I'm always questioning, is there a better explanation? Can you show me a better model for these phenomena that we observe? Well, a better model would have to be able to answer these questions. The cranial bones aren't fused, we saw that, unlike the sacrum, so why isn't the cranium fused? Why are the articulations between those bones so complicated? And why are they so different in different parts of the skull? Particularly in an adult, whereas in the child, they are at first very simple and very linear and not very different into different parts. Why does the CSF have all of those constituents in it? How do brain cells get inputs for their functioning? The nutrition, the hormones and signaling molecules, and also the proteins and building blocks to grow and evolve. How do you get venous return to the heart when you're lying down? And why don't the venous sinuses ever clot? So the takeaway from this is these principles of osteopathy in the cranial field, as described by Dr. William Sutherland, gives us the best model available today in medicine. And going back to the concept of evidence-based medicine, as I just highlighted, osteopathy in the cranial field fits all of the evidence, the sum total of everything that we know and that exists, better than anything else we have. In addition, when we use it to treat, we treat what we find. We use our clinical experience and judgment to take that body of knowledge and apply it tailored to the patient who is on the table. And patients value it. They value feeling heard and seen. They value feeling touched. And they certainly value having their pain relieved. So osteopathy in the cranial field fits the definition of evidence-based medicine in a way that actually nothing else can compete with. Thank you for your attention.